And now we come to the end of the section. The next program is the opening keynote section in the theme of From Local to Global, Equipping Future Physicians to Tackle Global Health Crisis by Professor Susie Schofield, Director for the Center for Medical Education, Associate Dean Quality and Academic Standard, and University Distance Learning Lead School of Medicine, University of Dundee.
Can I start by saying what an honor, what an absolute honor to be here. Thank you so much for the invitation. Thank you to our hosts, to the honorable guests, and to the students and faculty. And I remember organizing my first international conference, and you're all still smiling. This is very good. This is very good. You've done an amazing job. So, this is my very first time in Thailand, and we're here till the 26th. So this is also my very first Christmas outside the UK. So I've got my Christmas earrings on. You may have noticed I had parrots and a jumper because that was in Scotland. So you've asked me to talk about from local to global, equipping future physicians to tackle global health crises. And we've already heard a fabulous story about what one young researcher thought was a failure. Somebody had beaten them to publishing. What an inspirational story to start this conference with, about how what might have initially been perceived as failure was turned into success, was turned into this realization that we don't work individually. We work as a community. We collaborate. We are not individuals in this. This is the most amazing job to be in. This amazing, amazing global family of medical researchers, and in my case, medical educators. So, you've had a short introduction about me. I am indeed Professor and I'm also a proud alumni of the University of Dundee. I did 2 of my postgrad degrees at the university, and my specialty is medical education. And I joined the Centre for Medical Education. This isn't me, obviously. This is Ronald Harden, Professor Ronald Harden, which many of you may have heard of the sort of the father of medical education. Himself someone who is recognised globally for the enormous amount of work not only he has done, but that recognition of the need to collaborate. I've also I'm distance learning lead and been associate dean for quality and academic standards, and I'm someone who is always totally in awe of the students. Totally in awe of the voice, the authenticity, the enthusiasm you bring. I am myself passionate about change management and about faculty development and bringing that student voice in to help with faculty development. And also, I'm very excited about my first trip to Thailand. It would be very wrong of me to not show who I have to thank. I haven't pulled this talk together on my own by any means, and I would really like here to thank 2 of my colleagues, Dr. Georgina Cairns, who is our BMSc lead for international health, and maybe, I didn't think to put her email up, but maybe if there's some connections we can make there with our BMSc, our intercalated students, and Professor Ellie Hothersall, who is the undergraduate lead, having for many years been the MBCHB lead and consultant in public health. So, why? What is global health? Why is it important? And what is the role of physicians? And of course then also, from my point of view, what is the role of medical education? Starting off with what is global health. The focus is improving health and achieving health equity for all people worldwide. Health equity, not equality. We're not giving each person the same amount. We are looking to see what the individual needs are to develop and support health equity worldwide. The targets are transnational health issues, determinants and solutions. The progress is dependent on collaborative study, research and practice. So I'm going to come back and back to that collaborative, that community. And I know here we are also welcoming a lot of online participants, again with that collaboration. So again, we had a nice story about computers and how, those of us who are old enough to remember when that sort of computer power started to come in, about what we could do with very little, but how much more we can do now. It involves many disciplines. So we're not working in our silos, both within and beyond public health medicine and health sciences. So it does require a shift in thinking, intersectoral and interdisciplinary thinking. And it involves the integration of population-based preventative systems, service-level health and social care actions. So bringing in the skills of those computer scientists, bringing in the skills of the people out there in the field, on the ground. What are our current global public health priorities? Goodness, there's a bit of a challenge putting together a talk on such a wide subject for just 45 minutes. So I've just picked a few things, thinking about the risks, infectious disease prevention and control, for example, HIV and AIDS, and of course something very much in our minds, COVID-19, and how certainly in the UK that caught us very unawares. Antimicrobial resistance, huge risk, and non-communicable disease trends. There's also the priority on strategic aims, universal health coverage, improved provision of healthcare for maternal and child health, and pandemic preparedness. And another priority is looking at the determinants in global public health, the international movement of people and goods, migration and trade. Humans have always migrated, there's always been trade. But think about the speed with which that now happens and the sheer volume. Digital dissemination of misinformation. Again, there has always been misinformation. But with the internet, with social media, the speed with which that misinformation spreads is a real challenge to the physicians of today and tomorrow. Real challenge for public health. How do we then work with our patients who come with all that misinformation? How do we help to improve their literacy in health and in engaging with that digital information? Commercial activities impacting health, climate change, and of course politics, where our politicians are moving the money, the lobbying that is going on. These are all challenges. So thinking globally and acting locally. What does that exactly mean? Well, initiative or study may be considered global if it is framed from a transnational perspective, if it aims to address an issue in a way that can have global impact. It seeks global solutions such as frameworks, strategies, policies, laws, and regulations. It's difficult enough to get everyone agreeing in one university. How do you get everyone to agree across the whole globe? How do you show the imperative to move with that global lens, that transnational lens? The impacts aim to improve health outcomes at a transnational scale. How many of you are familiar with the policy window? Hands up, anyone? Yep, few, not many hands. Okay, so this is something that we use a lot in global health. And when Dahlgren and Whitehead back in 1991 came up with this rainbow, they didn't realize it would have such an impact. It's a nice, easy framing for starting with those individual lifestyle factors, the age, sex, hereditary factors, then moving out to the social and community networks, and then the general social, economic, cultural, and environmental conditions. So their original paper, 91, they revisited it 30 years later, and I do recommend certainly reading their revision, their looking back, their reflection of it 30 years later. This thing that as young, keen researchers they had developed with no idea how it would be used, how it would be used so widely, how it would be used in ways they'd never imagined. And it's a really nice little story about 30 years on from these researchers. So it's a nice paper. I'm sure a lot of us are familiar with the Global Goals for Sustainable Development developed by the UN. Health is a precondition as well as an outcome and an indicator of economic and social development. And the relationship between health and well-being and the UN SDGs is bidirectional. And of course, the one we really always think of first for global health is the third one, good health and well-being. So, what are the targets of this one that really wants to ensure healthy lives and promote well-being for all, at all ages? Lots of targets, and you can certainly go and read more about those on the WHO's site. Reduction of maternal mortality, ending of all preventable deaths under 5 years of age, fighting communicable diseases, ensuring a reduction of mortality from non-communicable diseases and promoting mental health, preventing and treating substance abuse. And there are targets set for the year 2030, and then we can look to see how we are measuring up against those, how we are progressing. For example, one target for 2030 includes a 90% reduction in the number of TB deaths and an 80% reduction in TB incidence rates compared with the levels of 2015. So that's a nice clear target. So we know exactly what we're headed towards, and then we can look at those 15 years to see how we're progressing. Thinking about the social determinants of health, income and social protection, education, working life conditions, food insecurity, water insecurity, structural conflict, unemployment and job insecurity, housing, basic amenities and the environment, early childhood development, social inclusion, non-discrimination, and access to affordable health services of decent quality. Those are not things that one individual physician can solve. Those are things we need to be working in a whole network of people. We need an awareness, though, with the patients that we're working with. The lives they are living are not the lives we are living. And I'm just going to pick on one of those now from Scotland. Scotland has quite a small tube line. I'm from England, I'm from near London, so I'm used to a much larger underground system. Glasgow has what's known as the Clockwork Orange, and basically you can go round it one way, or you can go round it the other way. This is the underground in Glasgow. And McCartney did a lovely diagram, a very good visualization of the impact of some of those social issues that I mentioned on the last slide, looking at the life expectancy along one part of this tube line in Glasgow. And you'll see top left, the male life expectancy in 2010 was 75.8. 10 stops down the line, it was down to 61.9. For females, 83.1. 10 stops down, 74.6. And that was because of all these issues, or many of these issues I've been talking about on the last slide, just highlighting unemployment, poor housing conditions, very different living conditions, different levels of education, income. Poverty is a huge, huge part of health inequality. The other reason I put this in is because this is a really, really nice diagram to bring a message over. And that's another thing that we really need, I think, to be increasingly aware of. And Mandy and myself, we're not staying in Thailand the whole time. We're nipping over, that sounds good, just nipping over to Singapore, as you can in Thailand. Much more difficult if you live in the UK. We're going over to Singapore and we'll be doing a workshop on visual abstracts. That real recognition now that to get messages over, visualization is a very powerful tool. And again, as an individual physician, we need some help there. Look at other people's, look to see how they visualize. Do you like this idea of visualization? For those of you thinking about making a visualization of your research, and I've been amazed at all these abstracts, I'm really, really looking forward to seeing some of the work that has been going on. Yes, we can think of the traditional paper, we can think of the traditional poster, but what change to the impact of our message if we can make some really nice, clear visualizations such as this? Is that also a better way we can communicate with our patients? Certainly in the UK, the average reading age for the UK is between 11 and 12. That is not going to be the average age of physicians. That is not going to be the average reading age of educators. So how do we get our messages across? I'm not going to go through the whole of this slide, just pick out a few. The commercial determinants of health. So private sector activities that affect people's health positively or negatively. The social, physical and cultural environments that are impacted through business actions and societal engagements. And here I have highlighted lobbying. And that is something that we can do. Physicians can lobby. And the commercial determinants of health impact a wide range of health outcomes. And one that is really, really coming to the fore for physicians as well as for the public that they serve during and after COVID is mental health. Commercial determinants of health affect everyone, but the young people are especially at risk. Unhealthy commodities worsen pre-existing economic, social and racial inequalities. Think back to that lovely diagram of the Glasgow tube line. Small island states and low and medium income countries face greater pressure from multinational actors. And we need effective public health actions to respond to these determinants, which are key, and this is from the WHO, key to building back better after COVID-19. I was going to put in a case study about COVID, but by then I thought, I've got far too much in here. So let's just come back now to thinking of the implications for global action. The global strategies and policies at macro level, social, economic, political, and cultural. There needs to be strategic, coordinated planning, and the delivery and evaluation of interventions need to be thought through a transnational lens. International collaboration on good practice, research and operations, such as surveillance systems, and how much misinformation is out there about surveillance systems. And yet we also need to consider the ethics behind surveillance systems and the collection of epidemiological data. Yes, we're acting locally, but we need to be thinking globally. We need to be thinking how local health issues can indeed escalate to a global crisis, and be aware of the interconnectedness of health systems. WHO initiatives, including the World Federation of Medical Education, thinking about accreditation in one country, people transferring to another country, either for a set time. For example, there's two of our former PhD, well, one former and one current PhD student in this room who have come over to Dundee for a set amount of time. There are others, I might include myself, who, having started in England, I'm now very, very settled in Scotland, and my qualifications have been recognised there. The knowledge exchange that goes on. Thinking about conferences such as this one and the global networks. Thinking about how we have indeed kept some of the good things we developed during COVID for conferences when we had to go totally online to develop very good hybrid facilities for conferences. And that does address both equity, because then many more people can attend the conference who wouldn't have been able to before, maybe for financial reasons, because they have caring duties that would not fit with them being away for a time, but also for climate change. We need to be thinking. Mandy and I thought considerably about this quite long journey by aeroplane. So that's why we're here for over 3 weeks and making sure we fit in as much as we can while we're here. And while we did our previous conference in Pakistan online this year, having gone in person last year. So it has, I would say, it's impacted how we're thinking, hasn't it, Mandy? Thinking about ethical electives, and I will share a case study on that. Now, the accreditation, the flip side of that is the brain drain. So the one I'm going to start with indeed is this, the case study, Increasing Understanding and Ethical Electives. So, electives. Most international electives with medical students from a high-income country involve travelling abroad. They did before COVID, during COVID, had to go online, and now increasingly, post-COVID, these students are travelling abroad. And they're travelling to low to middle-income countries. And this paper done by my colleagues in 2019 looked at what was happening and looked at who was providing a more structured approach to medical electives. They found that electives were largely unstructured and the students were unprepared, which could lead to problematic outcomes for students and also for both sending and receiving institutions. And for these health communities in low-income countries, problematic outcome for them was a huge issue. So in Dundee, led by Professor John Dowell, structured electives were developed, and these programs provide significant pre-departure training in global health and ethical dimensions of electives. The support and monitor not only during the elective, but a post-elective debrief. So you've got support before, during, and after. And the programs were developed on the basis of long-term engagement between the institutions. Yes, each student might go for 2 months, 3 months, but then the next year there would be other students from that same institution. There was a bi-directional dialogue between the institutions, an element of reciprocity. I did say to Mandy yesterday, maybe I should choose a different word for that. I find that word quite difficult, but you know, I'm not going to try and say it again. Recognise difficult ethical contexts in which electives take place and identify the problem of volunteerism. Volunteerism, where someone goes as a volunteer, but there's quite a lot of tourism, and that is primarily beneficiary to the medical student. So the last two highlight the unequal relationship between the sending and receiving institution here, largely mirroring unequal relations between the global north and the global south. So getting students to really recognise these last two. There's something, it's a bit like unconscious bias, that is there within us. It's that understanding, an understanding of the impact that we are having. Ethical electives should explore the aims of the elective. Why are the students doing the elective? What are they hoping to get from it? The factors influencing the destination and the specialty choice. As I say, that awareness of the concept of medical tourism. And for you students, the attitude to your elective, potential language, culture, and ethical issues, and knowing your environment. They are hugely rewarding for all. It's an excellent way of introducing global health issues. And this is something that we can really share our passion. The students research global health issues at their elective destination. The students can then share their passion with the following year's students going to that destination. Thinking also about that research, thinking about how this year's research is then built on by the next year's research, is then built on. So thinking about all this, how things build. And also thinking about the risks, communication, personal health, clinical risks, accommodation, travel and leisure, people and culture. And the second case study I've chosen is antimicrobial resistance, AMR. As I say, many case studies I could have chosen from, and I'm sure when I see your presentations and posters, those will identify some really key case studies. So again, this is multi-sectorial as well as multinational and transnational as a health threat. WHO declared AMR as one of the top 10 global public health threats. Problematic AMR is observed in viral, bacterial, fungal, and parasitic pathogens. And the primary drivers are misuse and overuse, inadequate water and sanitation infrastructures. The impacts and implications include increased mortality, morbidity, health system costs, transmission and impact of endemic and pandemic disease, leading to economic productivity decrease and decrease also in intended medical outcomes. And something certainly that we are doing in the UK is, as physicians, a lot of education with patients to reduce prescriptions. However, because certainly in the UK we seem to have an addiction to cheap food, it's used a lot in farming, in agriculture, to increase the amount of milk, for example, produced by our cows. We drink a lot of, we have a lot of dairy in the British diet. And so this is a way where we can't work alone. The health service cannot work alone to solve this problem. It needs to be working with governments, with agriculture, balancing up these conflicts. And we know that the development of new antimicrobials is highly limited. If we look at the burden transnationally by infectious syndrome, now again, I'm not going to go through the whole of this graph, but this is modelling using 2019 data on 23 pathogens, 88 pathogen drug combinations across 204 countries. And the estimated antibiotic-resistant pathogens were responsible for 4.95 million deaths, nearly 5 million deaths. So, huge, huge problem. Again, paper this is from is Murray et al., 2022, looking at the global burden. Murray et al., they also looked at the burden by geographic region. And oh, surprise, surprise, the burden is highest in low resource settings and lowest in high resource settings. And this graph is for all age death attributable to AMR. In the West Sub-Saharan Africa, 27.3 per 100,000 versus in Australasia, 6.5 per 100,000. So very much lack of equity there. So what are our strategic priority objectives here? We need to rebalance investment in drug development and improve access to all levels of antimicrobials in low to middle income countries. Development of pharmaceuticals targeted to the multi-drug resistance pathogens with high rates of infection in healthcare and residential care settings, and infection control and prevention in healthcare settings, especially most common hospital-acquired infections. We need community prevention with a focus on water, sanitation, and hygiene in low-income countries. We need improved vaccination coverage. And here's another example of where there's an awful lot of misinformation that is being spread across the internet. So how do we then improve vaccination coverage? Reduce human exposure to AMRs used in agriculture and aquaculture, and expand and strengthen antibiotic stewardship programs and investment in infrastructure. For example, development of more labs in those low-resource countries. A lot of the labs are currently focused in the high-income countries. And here are some examples of transnational collaboration, strategic objectives, global antimicrobial resistance and use surveillance system, GLASS, One Health, the 2015 Global Action Plan on AMR. Remember those targets that were set in 2015, targets set for 2030. There's a World Antimicrobial Awareness Week in November, and global antibiotic research and development partnerships. And maybe some of the students here, this is an area you are already or will be getting involved in. Our responsibilities of the global physician: primary care, public health, policy advocacy, and awareness of the ethical considerations in global health. How do we equip the future clinicians? Through education and training, the importance of incorporating global health topics in medical education, key competencies for global health, those cultural competencies, disaster response, epidemiology, equipping future clinicians for those interdisciplinary collaborations, working with other health professionals, NGOs and international organizations, building up networks and partnerships. And those networks and partnerships maybe some of them starting here in this room, this weekend at this conference. Fantastic opportunity to start building your networks. And there's technological and innovative approaches, leveraging technology for health telemedicine data analysis and examples of innovative solutions in global health. So, bioethics. I've mentioned a bit about ethics, that multidisciplinary study of response to moral and ethical questions. And there's a couple of quotes here I thought I'd share from Dr. Russell D'Souza, the first one. To advance the field of medicine, we must embrace a future where healthcare education is deeply rooted in humanistic and socialistic principles, fostering not only skilled practitioners, but compassionate advocates for all patients. So maybe you were thinking your all patients was locally, but maybe now you're thinking more with that transnational lens. Actually, who are my patients? And this from Ricardo Leon Borges, who is the current president of the WFME, who we were lucky enough to meet in Pakistan. Bioethics is crucial to the humanization of healthcare because it integrates ethical reflection, respect for human dignity, and compassionate care into medical practice. By teaching future healthcare professionals to engage with patients on a moral and empathetic level, bioethics ensures that the humanity of both the patient and the healthcare provider is upheld. So this is also caring for yourselves as healthcare professionals. fostering a healthcare environment based on respect, empathy, and fairness. And for those of you interested in this area, there is a UNESCO Bioethics core curriculum that was developed in 2022. It has 10 principles, and here I've just thought about each one with the relevance to education. So the first principle is enhancing patient-centered care, and that is very much in the way we deliver medical education, to view as a whole individual with values, preferences, and rights. The second principle, promoting empathy and compassion, responding to the emotional, psychological, and physical needs of patients, taking that more humanistic approach, that holistic approach. Number 3, respect for human dignity and rights, respecting dignity of patients, avoiding paternalism, and treating patients as objects. So we need to move away from that. And I think also that's very much where those ethical electives started off, avoiding that paternalism, that higher income country coming to save the lower income country. That's not how it works at all. Addressing ethical dilemmas with sensitivity. So providing a framework to address complex moral dilemmas. Education needs to provide a safe space to explore. A safe space to explore some very, very difficult ethical dilemmas. We have a current one going on in the UK at the moment about assisted dying. Currently, assisted dying is not legal in the UK. It is legal in Switzerland. People, when they have reached a point where they want assisted dying but can still travel, they go to Dignitas in Switzerland, whereas they may want to live longer, but they feel that that's their only option. There's been a very, very emotive debate with people from both sides of the argument and those in the middle, in fact, the whole spectrum. So we need to be providing a safe space in our education for students to start discussing those issues. Encourage cultural sensitivity and inclusivity, to teaching professionals to be aware of and responsible to diverse cultural beliefs and practices, to reduce marginalization, respect of different worldviews. Number 6, fostering ethical communication, providing guidance and safe practice for effective ethical communication suited to patient needs. Number 7, build trust in healthcare relationships. How do you, as clinicians, foster a relationship of trust with the patient? And how do physicians help that? Think about the importance of role modeling and the hidden curriculum. Role modeling also of the older student with the younger student, the more senior student, junior student, and that hidden curriculum. Number 8, addressing power dynamics in healthcare. Shared decision-making, empowering patients to express preferences and concerns, reducing feelings of vulnerability. Number 9, navigating technological and ethical advances. And of course, one very much in our minds, both as physicians and educators, is the rapid advances in AI, but also genetic testing, personalized medicine. Through all of these, human needs and ethical considerations must remain central. And the last one, commitment to social justice and equity in healthcare. Awareness of the distribution of resources and disparities, and how clinicians can work to reduce them. And the last thing I wanted to bring to your attention, now this is so hot off the press, that it's actually under an embargo. But one of the authors, Ellie Hothersall, I have checked with her when she sent me, she said, but it is embargoed. And I said, well, how can I talk about it at an international conference? And she said, well, I'll check your slides. Yep, that's absolutely fine. So there's a lot of words on here. This is the schools, this is all our medical schools in the UK. They have come together to look at what technological competencies should be within the curriculum in medical schools. So this is UK-based. And they very much looked at the what, the how, and the why. And I've already mentioned a few areas where we have to be understanding of this, not only locally, but globally. So thinking about data governance and management, health informatics, digital identity, safety and security, the use of artificial intelligence in healthcare, clinical academic research, digital diagnostic algorithms, precision medicine, digital health literacy. Remember, I've already mentioned that for our patients, not only for us. Health inequalities, personal health records, foundations and principles of health information systems. Again, think about how we need that for transnational monitoring of how we are advancing towards our targets we've set. And professionalism, ethical, legal, and regulatory considerations in digital health. And of course, it wouldn't be a talk in 2024 without a little bigger mention of artificial intelligence. I'm not going to read out this whole slide. As I say, this is just taking some key points from this report. But I thought I would talk about number 2 and number 3. Critiquing. We need our students to be able to critique the limitations of and the barriers to using AI in healthcare, as well as the benefits, and explain the role of big data for global, for transnational health. We need an understanding of big data in healthcare data science and delivery, the collection, the analysis, the reporting. So, get involved locally. Community health projects, look at local health departments, look at volunteering and outreach programs, but also look out, students, for those global opportunities, international fellowships, global health rotations, working with NGOs, and also those increasing online conferences and courses and resources for continuous learning. And this is great. You can't see, but the numbers have just gone red. And my last slide. So I would like to thank you very much. Thank you.
For anyone who needs a further qualification, feel free to ask Dr. Susie by using the microphone on the two sides of the auditorium. Thank you. Does anyone needs a further qualifications or any questions?
As for any keynote, there was a lot in there, I think. I hope there was something to interest everyone. It's always a bit concerning when you're asked to do a keynote thinking, right, which bits shall I keep in and which bits shall I leave out? As I say, I'm very much looking forward to seeing the work that you've been involved in. I hope some of the ideas there you will be very familiar with already, and some of them I hope there's some new thoughts there. Some things sparking. I will be around for the whole 2 days, so if anyone wants to come and talk to me or ask me questions. Another area that our students have been very involved in is the planetary health card. Has anyone here been involved in the planetary health card? Again, it was one of the many case studies I thought of. I thought, no, I'll leave that out for now. But it's very much looking at how we measure how well we are doing as an individual medical school as far as planetary health goes. So that's another interesting area. Again, it's a student-led initiative.
Thank you very much, Dr. Susie Schofield. Next, I would like to honor Major General Professor Pachet Leungkanchanaset to the stage to offer the token of appreciation to Professor Susie Schofield. Thank you.
Thank you so much.
Thank you very much, Professor Susie Schofield. That's the end of the opening keynote.